dehydration, how we approach those patients, how we classify the patients with dehydration. Patient. I'm just in the introduction of the subject. So be patient and focus on the talk. And as I said, this is making it very important. So that's why we always repeating inspiration on how to manage patient with dehydration. Yesterday, you are examined as a self-assessment quiz of a case study of dehydration and fluid therapy, and most of you get high marks, but most of you miss the most important question, which is to assess the degree and the type of dehydration. Now, after finishing this session today, we will make a review for the why you are making a mistake about how to assess the screen share. جعفر ليش متأخر؟ الموعد الساعة 9. أنت جاينا 9 دقائق.
السلام عليكم دكتور. عبالي يعني ب9:30 دكتور.
عبالك. مرة ثانية انتبه على الموعد.
إن شاء الله.
شباب بدل شير سكرين.
صار بعد
ما بدأ عندكم شير سكرين؟
دكتور بعد.
اوكي شوف. وكذلك نورا عبد الكريم متأخرة. وخش. اوكي. نبدأ recording. هسه بدأ عندكم شير سكرين.
اي بدأ.
Okay. So all of the or most of the information we will present today is found in the lecture of dehydration and the fluid therapy in the fourth class. But we said, because of the importance of this subject, we will repeat it more than one time. So firstly, we have to define what is the dehydration. Of course, dehydration, it is a state of physiologic disturbance for the fluid and salt or electrolytes of the body. It can happen in many conditions. So dehydration, it is not a disease per se. It is a condition, could be present in more than one disease. So it may be a sign or it may be a symptom of a disease. And of course, when we say dehydration, the word D, the prefix D, it means the removal of something. So hydration, it means adding water to something. Dehydration, it means removal. Yes, we talk mainly about the fluid content, about the water of the body. But the abnormality is not just relating to the water content. it's also involving the electrolytes. So always there is electrolyte disturbance happened with the state of dehydration. Now, the causes of dehydration. Of course, the deficiency or decrease in the total body water content, it may be due to decreased intake, or it may be due to increased loss, or it may be there is a translocation of the fluid inside the body from one compartment, from one side to other, affecting the general manner of the fluid content of the body. So if we talk about the decrease of fluid intake, this is a common cause, especially in the situations of the starvations or famine, or there is decrease of the water supply that happened in certain areas of the world. Today we are in Ramadan, and during the day we avoid to take water. We prevent ourselves from drinking water. So it may be a state of dehydration that could happen. Of course, for those who the adult can compensate the decrease of fluid intake for a time more than the pediatrics. But in pediatrics, of course, if there is a decrease in the water intake for a certain time, the dehydration will appear. Not just because of the inability of the body of children to accommodate or to compensate, but because of the high total body water content in the children, so making them, when there is a deficiency of the water intake or the water, the dehydration will appear clearly and rapidly more than the adults. So the other main cause of dehydration is increased fluid output. This can happen frankly and most commonly, especially in pediatrics, in cases of the GI loss, like in diarrhea and vomiting. And the most common cause for the diarrhea and vomiting, as you know, it is the acute gastroenteritis. The renal loss, it may be lost more than the physiologic levels through the kidney, so in conditions of the diabetes insipidus, and if in uses of iatrogenic diureticuses, or in the interstitial kidney disease. And of course, all these conditions will lead not just to decrease in the total body water content, and this means the dehydration. Of course, this will lead to disturbances of the electrolyte status of the body. It may be also increased through what's called the insensible water loss. This is through the skin and the process of what's called the perspiration, not the respiration, perspiration. This is the evaporation of the water or the fluid from the skin. This can happen especially in cases of fever, or the excessive sweating in hot weather or after exercise, or in cases of hyperventilation. If it is more than the physiologic level, also it will lead to dehydration. The third cause is the fluid translocation, as we say, like in burns or in ascites. There is a shifting or movement of the fluid from one compartment to other, to the third space, as we know, and this will lead to the dehydration. This means the decrease in the intravascular volume of the fluid inside the body. Now we are facing a fact that infants and young children are at high risk to develop dehydration. And we should know why. And actually we have 5 causes making the infants and young children with a specificity to prone for the dehydration. And if they develop dehydration, the dehydration may be risky or severe to the levels that is affecting negatively on the general health of the baby. The first cause, as we said before, it is the larger total body water content. You know, the total body water content in the body of the baby, it may reach up to 80%. And this is in neonates after birth, and especially in preterm baby, and then it starts to decrease with time to reach to the adult level, and then it will decrease more when the human being reach to the age of the elderly age group. So larger total body water content. If there is deficiency, it will be apparent more than in adult. This is the first cause. The second is the high basal fluid requirement because of higher metabolic turnover rate. You know, the growth and development in the babies, in the children and young infants occurring at a high rate more than other age group. And of course, this necessitates a process of metabolism on different levels. And you know, the metabolism, it will use the water as a waste as initial substrate for processing of the metabolism. So this is called the higher metabolic turnover using the weight. More consumption of water. This is the summary. Third is the high ratio of surface area to weight promotes the significant evaporative losses. You remember we said there is a way of losing the water through the skin by the process of the insensible water loss. So in children, there is a high ratio of the surface area to the weight, more than the adult. So the loss through this way, which is insensible, making them at risk of dehydration more than the older children and the adult age group. And the fourth cause is the immature renal tubular reabsorption process. The kidney cannot concentrate the urine. So there is a lot of water passed physiologically through the kidneys because the reabsorptive function of the kidney is not mature yet to the level that keeping the total body water content at physiologic manner. The fifth, which is very important really in a practice, which is the inability of the infants and young children to independently meet their own needs. For you, if you feel thirsty, you will go to the refrigerator and you will take your own of the water or fluid, whatever, as you need. But for the children, they need someone to give them water. So if the mother is busy or it is ignorant or didn't care proper care of her baby, making there is a deficiency of the intake. You know, the thirsty or the thirst, it is of two types. We have the psychogenic or the psychologic thirst, and we have the physiologic. The psychogenic is that feeling you need to drink water for no reason. You just need to rehydrate yourself. And that's what happened during the time of the fasting, especially in the nights of Ramadan. عادة شرب المي الناس تشرب مي هواية بالسحور عبالها انه هذا this will prevent the dehydration or this will prevent the thirst during the day, and this is wrong, of course. So this is a psychogenic thirsty. But the physiologic thirsty is when the osmolality of the plasma increasing more than the normal level, which is to 85 to 295 milliosmoles per liter. This will initiate or will stimulate the production of the anti-diuretic or release of the anti-diuretic hormone to keep the amount of the fluid from escaping through the kidneys. And so that's why the urine output will be decreased and will be concentrated, and the patient or the person will feel he is thirsty. And if he go to take his need of water or of fluid orally, the process will be within the physiologic level and will be corrected. But if it is for more than time, he cannot reach to the water, or there is absence or deficiency of the water or the fluid, of course, the physiologic thirst will be will predispose for dehydration. In adult, because he can meet their own needs, so there is no reason for dehydration from the physiologic thirst. But in pediatrics, in infants especially, they need someone to give them water. So that's why this is very important. And of course, this is why when we manage or when we approach cases of dehydration, we give the awareness for the mother to prevent the dehydration by giving the fluid to their children and to prevent the dehydration by this way. Now, we will go to talk about the complications of dehydration. It is simple and reversible if it is managed and diagnosed immediately or early. But in cases of delay management or improper management, the complications will happen from the dehydration, or sometimes may happen from the poor or improper management of dehydration. So first is the hypovolemic shock, because of course there will be, in cases of very severe dehydration, there will be a decrease in the intravascular volume, and of course this will lead to hypovolemia, and hypovolemia will lead to shock if it is not managed. Seizure due to electrolyte disturbance, and the most important, it is the sodium. So if there is increase or decrease in the sodium, a hyper or hyponatremia, it will lead to seizures, and its harmful effect on the brain of the baby, especially if it is recurrent. Acute kidney injury, because hypovolemia, there will be a reduction in the perfusion, and we will find ourselves in a situation of the pre-renal acute kidney injury. And we have the cerebral edema, cerebral dehydration with subsequent intracranial hemorrhage and thrombosis. Actually, cerebral edema and cerebral dehydration, or we can call it the central pontine melanolysis, this is maybe initially presented or be an initial complication of the dehydration. When we talk about cerebral edema, so we talk about the hyponatremic dehydration, and about the cerebral dehydration, or about the central pontine melanolysis, we talk about the hypernatremic. This may be initial complication, or it may be a complication of a bad management of the hyponatremic or hypernatremic dehydration. And this is, of course, for cerebral edema, it is common. For the central pontine melanolysis, also it's rare, but it is a life-threatening condition. The renal vein thrombosis due to hemoconcentration. Of course, when there is decrease in the intravascular volume, there will be an increase in the osmolality of the plasma, and there will be increase in the viscosity, making it is prone to develop a thrombosis. So the most important affection of this complication is the renal vein thrombosis. Again, it may cause acute kidney injury. Coma and death. Of course, if these all complications happened, and if there is no correction, delayed or poor, the net result of the dehydration, it will be coma and death. Now, it is important to classify the dehydration into three: clinical and biochemical. When I say clinical, this is because the clinical presentation of these types of dehydration, it may be different. And when we say biochemical, because this classification is based on the level of the serum sodium. So it may be isonatremic dehydration, or sometimes we call it isotonic. And this is depending on the serum sodium. The normal serum sodium in eovolemic state. This means when the intravascular volume is normal, it is between 135 to 145 millimole per liter. But in cases of dehydration, we will increase the range to be between the 130 to 150 millimole. If we go to the hypernatremic dehydration, of course, we mean the serum sodium more than 150. And when we say the hyponatremic dehydration, or we can call it hypotonic, of course, the serum sodium is less than 130. Now we will talk about each type of dehydration specifically and separately. The isonatremic dehydration. Here, there is a balanced loss of sodium and water. This can happen as the most frequent and the frank example is an acute diarrhea. In acute diarrhea, there will be a balanced loss of the fluid, water, and the sodium, giving the isonatremic dehydration. So, because there is an isonatremic dehydration and a balance between the loss of sodium and water, there will be no change of the osmolality between the intravascular or the extracellular and the intracellular. So there will be no shifting of fluid from these both compartments. So this is the most common type, and this is occurring up to 80% of the cases. And we say acute diarrhea, and acute diarrhea is very common. It's the commonest problem in pediatrics, especially in those less than 5 years of age. And of course, because there is no shifting of a fluid and electrolyte between the compartments, and there's no disturbance of the electrolyte, so it has the best prognosis. But if left, it will lead to a disturbance in this balance and will go into the complication of either hypo or hypernatremic dehydration. As I said about this, now we will go to the hypernatremic dehydration. It is the worst prognosis. Here is the water loss exceed the sodium loss. So the net result will be a hypernatremia. It accounts for about 15% of the cases of the dehydration. And of course, it can happen in acute diarrhea, but it can happen also in inadequate water replacement and in diabetes insipidus. Of course, diabetes insipidus, there is a loss of water through the kidney more than the normal, and the net result is hypernatremia. And high fever also causing hypernatremia because there is a loss of just water from the process of increased insensible water loss through the skin. So the net result will be hypernatremia. So if they ask you why in high fever the patient is at risk to develop hypernatremic dehydration, you will say because of the increased insensible water loss through the skin. As I said, it is the most dangerous form, and it carries a high rate of mortality. It may be up to 20%, here, or in severe neurologic, it may be up to 10%. This is, of course, it may be not just because of the hypernatremic dehydration initially, it may be because of the bad management. And of course, I will repeat this phrase or this statement, bad management. The bad management, the improper management carry the risk at the same level of the dehydration itself. Because it is a hypernatremic dehydration and there is a loss of water from the intravascular compartment from more than the sodium, so there will be shifting of the fluid from the intracellular to the extracellular. And the net result will be cerebral dehydration, cellular dehydration in general, but the most important organ is the brain. So cerebral dehydration, and we say it may lead to the rare but life-threatening condition, which is the central pontine melanolysis. And but this fact, which is the shifting of a fluid from the intracellular to the extracellular, carry a potential risk, additional risk, which is there is a partial preservation of the intravascular volume. So the children may be less hemodynamically compromised, not like in isonatremic or in hyponatremic dehydration. And for this cause, the affected infants will present it to us late. they will not present it to us as in the early hypernatremic dehydration. No, when it would be severe hypernatremic dehydration, they will present when the signs of dehydration become more obvious, and when there is a failure of the compromisation of the intravascular volume because of the shifting between both compartments. So, what about the clinical features for the patients with hypernatremic dehydration? And we say they will present late. So how we can diagnose these patients with hypernatremic dehydration? Those patients, if we go to the skin, to their skin, and especially to the skin of the abdomen, we would find them in a manner of what is called a doughy skin. Doughy, it means, it is from the word dough, which means العجين بالعربي, or sometimes we call it the velvety. Velvety, it means المخملي. Why? Because there is a hemodynamic compromisation, and there is a preservation of the intravascular volume. So there will be a partial compromisation of the tissue perfusion. So there will be no a state of a prolonged skin turgor that we found it, loss of tissue elasticity that we found it in the isonatremic or in hyponatremic dehydration. So if we go to the examination of the degree of dehydration depending on the skin turgor, we will not reach to the real assessment. We will say this is a mild or this is moderate if we depend on the skin turgor because of this reason. So how we can manage or how we can judge this is a severe hypernatremic dehydration? We go to other signs, which is the lethargy. When we say the baby is somnolent, this is mean it is lethargic, drowsy, and this is a sign of severe dehydration. And when you just touch the baby, when you just stimulate, he will be hyper-irritable and he will cry in a high-pitched cry. So this is a specific sign suggesting the hypernatremic dehydration more than the isonatremic or the hyponatremic dehydration. Because in that type of dehydration, the picture of severe dehydration will be complete. But here, there is a discrepancy between the level of the consciousness of the baby and the activity of the baby and the tissue elasticity. I mean the doughy skin by just pinching the skin of the abdomen of the baby. If we go to the hyponatremic dehydration, in hyponatremic dehydration, of course, there will be a loss of sodium more than the water, or there will be a retention of the water and to compensate the volume depletion. So the net result is hyponatremia. This is again can happen in acute diarrhea. And this is account for about 10% of the cases of dehydration in general. And in hyponatremic dehydration, because there is a hyponatremia, again there will be a shifting, there will be a movement of the fluid, but in the toward the cells. So it is from the extracellular, from the intravascular to the intracellular, leading to what? Leading to two problems. The first is exacerbating the intravascular fluid depletion. This is the opposite of in hypernatremic dehydration. So the baby with hyponatremic dehydration will present early because the signs of dehydration will become obvious more than even the isonatremic dehydration. There will be fluid depletion intravascularly. This is the first. The second, movement of the fluid to the intracellular will be, there is a cellular edema. And of course, the most important is the cerebral edema. And cerebral edema, it will affect the level of the consciousness of the baby, and if it is not managed, if it is not diagnosed early and managed well, you know the net result of cerebral edema. It leads to coma and death. So it is most typically occur in older infants and children, those given the low sodium fluid. This has happened in a practice frequently. How? When the baby develops diarrhea and vomiting, and he becomes thirsty, the mother at home tried to give him a tap water, just water, or to give him something which is low in sodium. So this will lead to what? This will lead to the hyponatremia, hyponatremic dehydration. And that's why we always advise the mother, do not give what's called the low beverage that's found in home. Not every fluid found at home is appropriate to be given for a patient with dehydration, because it will lead to hyponatremic dehydration. Now, in practice, I will ask you to this point, after explaining the types of dehydration. The question is it possible for a single patient to have 3 types of dehydration at one condition? Patient, his age is 10 months. Is it possible for him to have at the same time, at the same illness, to develop isonatremic, hyponatremic, and hypernatremic dehydration, or it should happen in different illnesses? Who will answer?
دكتور possible.
How?
دكتور مثلا هو أول شيء صار عنده أكيوت دايريا راح يصير ايزوناتريميك ديهايدريشن، بعدين يعوضوه فلويد، خلينا نقول لأن المذر وحدي بالبيت اشتغلت فلويد سوتها هايبوناتريميك، يعني كان لو صوديوم فلويد. بعدين بالأخير يجوز بالمستشفى مثلا طفت يعني الفلويد يعني كان هم يعني باد مانجمنت هم يصير هايبرناتريميك in the same condition.
You are right to some extent. The arrangement is wrong. Firstly, yes. The answer is it is possible for a child, for infant, to have 3 types of dehydration at the same illness, at the same, not the same time, I mean the same time, but at the same illness. Firstly, if the patient has acute diarrhea, gastroenteritis, some form of acute diarrhea and vomiting. So firstly, he may develop balanced loss of fluid and sodium, and this is isonatremic dehydration. For a certain time, the baby entered to the state of dehydration, but the mother didn't give him fluid. So what would be the result? The result will be a hypernatremic dehydration, because the body will lose more water, but the sodium will preserve to a certain level. So firstly, isonatremic dehydration, then the baby will develop hypernatremic dehydration if he cannot meet or if he not receive a fluid to correct the dehydration. Then after that, the mother notice or give the attention that her child become dehydrated. Of course, the form of become thirsty or lethargic. So she tried to give him tap water, fluid low in sodium, giving him in a high amount because the baby is thirsty, taking eagerly the fluid. So the hypernatremia will be corrected again to be isonatremic, then it would be hyponatremic. So the correct arrangement is yes, iso, hyper, then hyponatremic dehydration. Now we will go to the clinical manifestations of dehydration. This is very important. what are the clinical manifestations of dehydration? Both signs and symptoms. So, it is important to recognize the clinical manifestations of dehydration, then to arrange it or to group it in certain groups of the clinical features. And the aim is to make a classification of the dehydration according to the level or according to the degree. So academically, we have 3 degrees or grades or levels of dehydration, which are the mild, the moderate, and the severe. So when we say it is a mild dehydration and it is up to 5% dehydration, we mean there is a loss of the body weight of the baby by a level of 5% of the previous weight. So we assume that we know the previous weight before dehydration. And weight. But in most of the cases, we didn't know the previous weight of the baby. So that's why we depend on the clinical manifestations. Then we say it is a mild, so it's mean 3 to 5%. It is moderate, it means 6 to 10. طبعا ال 10 تعتبر هي من severe dehydration. Yes, in this classification they put in moderate, but it is 6 to 9. The real is 6 to 9, and the severe dehydration started from 10 to 15%. So if you see here on this side, this is the criteria, or this is the, what I say, the parameter, we depend on it. So when we talk about the skin, we have the skin turgor, we have the color, we have the mucous membrane. And it will range from the mild to moderate, as you see here. When we talk about the hemodynamic sign, this is mean the volume of intravascular fluid. So of course, the parameters are the pulse, the capillary refill, the blood pressure, and the perfusion. Now, I will ask you, what has happened early in the state of dehydration? Of these parameters, I mean, what is the earliest to respond? Is it the pulse? Is it the capillary refill, the blood pressure, or the perfusion?
pulse.
هسه هاي افترض جايك بام سي كيو، هذا راح يجيك ام سي كيو. خلي اعيد السؤال. Of these 4 parameters, which would be the first responding to dehydration? The pulse, the capillary refill, the blood pressure, or the perfusion? مين راح يرتب لي اياهن؟
The blood pressure.
The first responding the blood pressure?
Really?
Okay.
Then pulse.
Firstly, the blood pressure, then the pulse. Or perfusion?
Third one?
Okay, with capillary refill?
At the end, يعني.
At the end. Anyone has...
So the first is the pulse.
The first is the pulse.
Yes.
Yeah,
And
the first is the pulse. And the last? What is the last?
the last is the blood pressure.
Very good. Very good.
Well,
The first
most postural blood pressure changes rather more early than the supine blood pressure.
We have two types of blood pressure, which is the postural, as you said, and we have what's called the mean arterial blood pressure. That is affected late. It is the mean arterial blood pressure. And when the mean arterial blood pressure decrease, this is meaning there is a decreased perfusion of the fluid of the blood to the cells, to tissue, or to organs. And the net result will be decreased auto supply and this will lead to multi-system organ failure. Can happen in any case of shock, and whatever the cause of the shock. But here we talk about the hypovolemic shock. But in septic shock and anaphylactic shock, what make the patient enter to the state of shock is decrease in the mean arterial blood pressure. So the first hemodynamic sign that is responding to dehydration is pulse, and the last is the blood pressure. And of course, in between there will be decreased tissue perfusion. We can get it from the signs like in the skin turgor or in the capillary refill. So if I go to the pulse will respond in two types or in two phases. The first, and I would not say the first, these two phases are the rate and the volume. So what do you think? Which is the first responding? Change in the rate or change in the volume?
Right.
Who answer me?
The rate is the first.
طلاب وياي راح انقطع النت.
أي دكتور تسمعوني؟
وياك دكتور.
The rate is the first. ايه اسمعك مو صار pause. I think the net is cut off. Okay, so the first responding regarding the pulse is the rate, not the volume. Because the rate, when there is a decrease in the, of course, the heart will increase its output, increase the cardiac output, and increase the cardiac output will increase in the rate, the heart rate, or in the pulse rate. This is the first. Then when the volume is depleted to the level of hypovolemia, of course, there will be decrease in the volume of the blood, of the pulse rate, sorry. So in cases of shock or pre-shock state, we found the pulse is weak, low volume. We can call it the thready pulse. And the rate is out of detection. We cannot detect the rate of the pulse when we reach the level of the hypovolemia. But now I have a question. I have another question related to the hemodynamic signs, because this is very important. What is specific to the hypovolemia? It is the pulse or the rate? It is the rate or the volume?
The volume.
Of course, the volume, yes. The tachycardia, it is the first responding, but it could be for other causes, exercise, drugs, fever. All these can, sympathetic overactivity, all these can lead to increase in the heart rate or the pulse rate. But what affects the volume, of course, it is the intravascular volume of fluid. So this is important, which is the hemodynamic signs and how it is changed according to the level or to the degree of dehydration. And of course, the other parameter is the fluid loss. I mean the urine out, and it may be anuria, absence of urination for a certain time. This is for the urine output, and for the tears, there will be a tearless baby cry without tears. Of course, we will go to the urinary incidence. We will find the specific gravity because it is a concentrated urine. It will increase. And for the urine sodium, we would find it also decreasing because of, especially in cases of the hypernatremic dehydration. Now, this is other classification for this is more practical. And you can go to each point separately and you can collect them to say, my patient has mild, moderate, or severe dehydration. You can revise it later on. Now, this picture will show the signs of dehydration again by examination. Well, suppose you are now at the emergency department and you are examining an infant with history of diarrhea and vomiting. So you will assess the degree of dehydration, starting from his head, going to fontanelle. For those with age of open fontanelle, is it sunken or not? Then go to the eyes to see if they are sunken and or tearless. And go to the mouth to see the dry mucous membrane. And of course, don't forget to focus on the level of consciousness. The baby may be conscious alert, may be drowsy, or may be irritable. Now, you'll go to the pattern of respiration. Here's the pattern of respiration. Look at the rate and the depth of respiration. You may find the respiration is normal, or you may find it rapid and deep because of the change in acid-base balance. What is the change that is mostly associated with dehydration, making the respiration is rapid and deep? Who answer me?
Metabolic acidosis.
Yes, metabolic acidosis. Yes, metabolic acidosis causing deep and rapid breathing. Now, if you go to the skin of the abdomen, of course you would make. But please mute yourself. When you make a pinch of skin of the abdomen, and why you choose the skin of abdomen, not other parts of the body? Because this is a loose skin. This is a loose skin. You can pinch it between your fingers and then release it. So normally there will be a momentary recoil of the skin, return to its normal state. But if there is dehydration, you will find what is called a reduced skin turgor, or prolonged, or decrease. All these terms mean there is decrease in the elasticity, and this is mean decrease in the tissue perfusion. This is the importance. If we go to the assessing the urine output, go to the napkins, and you can ask the mother by history about how many times you change the diaper. You'll find the napkin is dry, so it may be it may be oliguria, or it may be absolute anuria. There is no urine output. And if you go to the hemodynamic science, we talk about the capillary refill. You are pinching the fingernail, then release it. Normally, again, there will be a momentary return of the normal color, but in cases of dehydration, according to the level or according to the degree of dehydration, there will be a delay. If it is 2 to 3 seconds, or it is a 3 to 4 seconds, or even more than 4. Of course, we talk about the pulse rate, and we assess the brachial rather than the radial, because it is difficult to assess in infants. And we should check the blood pressure. Of course, there will be hypotension. And if we talk about the capillary refill, we can use it or we can assess it not just in the fingernail. We can assess it on the sternum, or we can assess it on the earlobe. And of course, because there is a dehydration, there would be a loss of weight. If we know the previous weight of the baby before the illness, we can assess it by the percentage. So there is a sudden weight loss, it may be up to 15%. يعني طفل كان وزنه مثلا 10 kg, so if he's losing 15% of his weight, so current weight, it would be 8.5, and it would be clearly to assess the weight loss. if he losing 10 or to 15% of his weight. Now, what you see in this slide?
Sunken eye.
Just sunken eye?
Lethargic, unconscious,
Maybe disturbed level of consciousness.
pale.
This patient, of course, has sunken eyes, deeply sunken eyes, and he is lethargic or drowsy. So both signs of dehydration present in these two slides, which is the lethargy and the sunken eye or drowsiness. This is the skin turgor. So because of severe dehydration in this patient, after release of the skin pinch, the tissue of the abdomen didn't return to normal immediately. So this is called reduced skin turgor or prolonged or decreased, as I said. All of these give the same meaning. This is another slide showing the reduced skin turgor. What are the signs getting in this slide?
So first, to reduce skin turgor.
Yes. The other?
There's sunken eyes.
It's not clear if there is sunken eye, but the clear is
Pale
Paleness.
baby.
what?
Paleness or pale baby.
Pale baby, no.
Irritability.
Irritability. This baby is irritable. Irritable because of the handling, because of doing this a sign of examination. So irritability.
دكتور عفوا شلون عرفنا irritability؟
This baby is crying. Look at his facial expression. He is irritable by just handling it.
شكرا.
What is the sign?
دكتور doughy skin.
This is the doughy skin.
This is the doughy skin. This is the sign of hypernatremic dehydration. So if we depend on it in assessment of degree of dehydration in hypernatremic, we will do a major mistake. We should go to other signs, which is, as I said, the lethargy and the irritability to touch. And what is other sign? The high-pitched cry. These are signs suggesting very highly the hypernatremic dehydration and the presence of doughy skin. Now, what is important is to know the dehydration, is to classify the dehydration. Now, how you clinically will use these information in management of the dehydration? This is what would be the in the rest of the time. Of course, history. Of course, in history, you would ask about if there is increased GIT loss through diarrhea and vomiting, or if there is decreased oral intake. You would ask about the level of consciousness at home. When you ask about history, so of course, before the patient is presented to you. So if the patient is lethargic, looks tired, or irritable, or he is alert, this is very important. Ask about the tears, the baby crying at home with tears or not. This is very important. And ask about thirsty. That's why we always focusing on this point. When the baby taking a large amount of water, take it eagerly or not. And so look at of these fluids. It may be water, juice, soda, and tea. All these called low beverage, low content of beverage. All these are hypotonic fluids. Using of it frequently in high amount would lead to development of the hyponatremic dehydration. And of course, you would ask about the change on urine output by asking about the diapers and the times and the manner of each time. We would go to the examination, and the previous picture show it. So general condition, from well to unconscious, decreases skin elasticity and dry mucous membrane. You look at the sunken eye, you know, an examination. You would look, then feel. You would look and feel. So in sunken eye, you would look, but in fontanelle, you will feel. In skin turgor, you will feel. In pulse, you will feel. In capillary flow, you will feel. But for the abnormal respiration, you would look. In the dry mucous membrane, you would look. General condition also. Then, after that, you will weigh the child. Weighing the child is important for 2 points. No is to know the degree of dehydration if you know the previous weight. Second, you would put the plan of management according to the current weight of the baby. After that, you would order a list of lab findings, but you would not wait for the results of the investigation. Yes, you will send to lab, but you will start your management. Then you will correct or you will change according to the results. Because as we say, the dehydration is a very critical and the time is crucial to start properly. So the first important is the serum sodium, because this is important to classify the types of dehydration. The management plan will differ according to the level of serum sodium. The arterial blood gas analysis to see the pH and the bicarbonate, because we say it's most commonly to see the metabolic acidosis in cases of acute gastroenteritis or in cases of diarrhea and vomiting causing severe dehydration. Serum potassium is very important because hyperkalemia happened with metabolic acidosis, and hyperkalemia may be a sign of acute kidney injury. So blood urea and serum creatinine is very important, and especially in severe dehydration. Of course, the blood urea will be increased because there is a pre-renal, this is what's called the renal shutdown, renal acute kidney injury, decrease in the renal perfusion. But the serum creatinine, because there is no interstitial kidney involvement, this is acute injury, so the serum creatinine would be normal. The general urine examination important, specifically the specific gravity would be high because it increased the concentration of urine, blood glucose, and what you expect, the patient would be hypoglycemic. CBC very important, especially to see the level of the hemo concentration. That's mean increase the PCV. Even patient anemic, it may have, or they may have high PCV because of a relative hemo concentration due to hypovolemia. Again, don't wait for the results of the investigations before starting the plan of management. Send it, but you should start because it is a matter of time. Now we go to the treatment, which is very important. And we should know the phases of a treatment. The first is the rapid expansion of the extracellular volume. Because you may have not just a severe dehydration, you may have a patient with hypovolemia, and you should rapidly resuscitate this baby and restoring the tissue perfusion by expanding rapidly his intravascular volume. The second, after doing that, after correction of hypovolemia, you should replace the deficit because the baby has a degree of dehydration. It may be the severe dehydration, and you have to replace the electrolyte disturbances and to correct the acid-base balance accompanying this abnormality. Then, the baby normally, or not just the baby, all of us need a maintenance level of fluid and of calories, of course. This is a normal situation. So here, you are meeting the nutritional needs of those patients. And finally, you should replace the ongoing loss. You admit the baby because he has vomiting and diarrhea, causing this a problem. Now you will correct the abnormalities happened because of it. But because the baby may have ongoing, or it's mean continuous diarrhea and vomiting, so you have to replace these ongoing. يعني مثل ما نقول بالعربي انت عندك شيء مكسور، سالفة المصريين مسورة وتخامت، فانت تصلح منها يظل خراب منه. You should replace the ongoing loss. انت ما راح توقف الفوميتنج والدارية. ايش راح تسوي؟ You will correct the effect, you will correct the disturbance by replacement of the ongoing loss. زين. هسه approach to severe dehydration. احنا عندنا 3 degrees of dehydration: mild, moderate, severe. All these are academic classification. This is academic classification found in textbook, found in universities, and all medical students should be learned about this. But we have another way of management, which is the WHO, which is more practical and more applicable in low sources regions. يعني مثلا في أفريقيا، في المناطق الفقيرة، عندنا بالعراق مثلا في مناطق في برايمري هيلث كير سنتر او في مستشفى ريفري، وانت تريد تبدي مانجمنت ممكن تبدي according to WHO not according to the academic classification and academic management. هسه according to academic اللي هذا لازم نعرفه بالبدايه. Firstly is the initial resuscitation. هاي اول شيء. Then plan the fluid therapy for the next 24 hours. You would put a plan for next 24 hours. That plan contain what? We will see. Then you have to replace and maintain the need of the fluid. And of course, you have to monitor and adjust therapy. Why? Because we say you put a plan for the next 24 hours. So suppose we are starting now at this time, this is 10:07 p.m. and we put a plan, but for 24 hours until tomorrow. Then the changes may happen after just a few hours. So you have to adjust your plan. How you will adjust, how you will check the changes? By the frequent monitoring of the patient after starting the plan. Firstly is the initial resuscitation phase. خلي منا شوية أبدي أحكي شوية بالعربي ما دام بدنا نحكي practical أكثر. شنو هو الانيشال resuscitation phase؟ شو راح نسوي هنا؟ احنا قلنا البيبي after يعني approaching to it and we judge or we assess the degree of dehydration and we said this is a severe dehydration with hypovolemia. شو نحتاج؟ نحتاج نسوي rapid restoration of the circulating intravascular volume and the treatment of shock if he is really in shock. شلون نعرفه he is really in shock؟ البulse، the blood pressure, level of consciousness, بعد شنو؟ الcapillary fill, الهيمودynamic signs, and even the urine output. لأن إذا ما urine output معناته شنو؟ معناته there is a severe reduction in the renal, the intravascular volume بحيث مدى يروح fluid to the kidney. زين؟ مو معناته الكدني بعد ما تشتغل، لا، معناته أنه مدى يوصل fluid to the kidney على مود يسوي لنا the process of filtration. زين. What is the initial phase؟ شو راح ننطي بيه؟ ننطي بالص. مو بلص. نسميها بلص غلط، هي بالص. Usually 20 ml per kg of isotonic fluid. وهذا حكينا وين؟ بالسيشن of IV fluid. بدون isotonic fluid we have to normal saline or ringer lactate. Have given over 20 minutes. 20 ml per kg. ليش isotonic fluid? Because isotonic fluid, there will be no shifting from the compartments. فمن ننطي الفلويد to the intravascular volume, it would be in the intravascular volume. يحقق الهدف, the goal of the initial resuscitation, اللي هو rapid restoration or rapid expansion of the intravascular volume. حطيناها over 20 minutes. Sometimes the baby didn't respond to the one bolus. ممكن شو نسوي؟ نعيدها. زين. احنا قلنا ممكن ننطي normal saline or ringer lactate. Ringer lactate عنده فد special caution or contraindication actually, which is should not be given in cases of hypernatremic dehydration. يعني إذا أنا by clinical judgment or by clinical assessment there is a suggestive signs of hypernatremic طبعا severe أكيد بدنا نحكي لأنه هذا احنا بدنا نحكي بالسيفير dehydration of hypernatremic dehydration. It's better or I should use normal saline, not ringer lactate. Why? هذه همين حكيناها بالبريفيوس سيشن. لانه الرينجر لاكتيت يعتبر in comparison with normal saline it is low in sodium content، فراح يسوي لي rapid decrease in the serum sodium and I should avoid the rapid decrease in serum sodium. ليش يا شباب I should avoid the rapid decrease in serum sodium؟ يا شابات، مو بس الشباب، الشابات وينهم؟ طلاب وياي؟
عفوا دكتور نسمعك.
يلعب ليش ما تجاوبون؟ اول شيء
ممكن يسوي سيجار يعني؟
لا مو لا تقول لي يسوي سيجر، كون تقول لي السبب.
يسوي cerebral edema.
سيربرال اديم، يسوي لك سيربرال اديم. هسه السيربرال اديم اذا سوت لي سيجر هم زين، هاي نبهتني اكو سيجر زين. مرات يجوز يسوي لي سيربرال اديم ما وصل للسيجر، يروح قبل البيشنت تو كوما اند ديث زين. او ممكن يصير سيجر بس without سيربرال اديم، بس الهايبوناتريميا قبل لا توصل السيربرال اديم. فانا الهدف اريد امنع الرابيد كوركشن على مود لا يصير سيربرال اديم زين. هسه ممكن تواجهني مشكله، وهي المشكله حقيقيه مو يعني افتراضيه. because of the hypovolemia اكو volume collapse، اكو collapse صاير، يعني there is no IV site available. اجي اريد افتح الفين القى ماكو فين، كانيلا ماكو، من اجي اريد احط ادور على فين ما القى زين. هسه هاي شلون الحاله؟ there is no IV access. وين نروح؟ نروح to the intraosseous access. شلون هذا الانتراوسيوس؟ through the marrow of space of the tibia. نروح على التيبيا قريب الني جوينت، هذا هنا فد marrow space full of sinusoid. I insert a special needle inside this space و start to give a fluid. يتحقق الريسوسيتيشن فيز، يرجع يصير rapid expansion of the volume، ارجع اخلي IV line through a peripheral vein. هاي المشكلة ممكن تواجهنا وتواجهنا وخصوصا بالبريفرال هوسبيتالز. يجي يريد يحط فين ما يلقى، فشي يسوي؟ يدز الطفل بوضعيته هذه الى ان يوصل مثلا الى التيرشري سنتر لايك يعني ناور هوسبيتال، نلقى الطفل هنا بعد ايش صاير بيه مور هايبوفوليميا، يعني his condition is worsened. لكن لو مثلا هو start to put intraosseous اللي هو very easy، لان هذا في bone marrow space especially it is bony area in children ف easily accessible، كان ممكن صار rapid correction. اكو فد other way انه put NG tube and start ORS، ممكن هاي ال ORS يسوي لي شويه rapid correction of the intravascular volume على ما يصير referral of the patient by ambulance to the central hospital. زين، هاي من راح نحكي
بالمراكز الصحيه اكو انتراوسيوس؟
لا بالمراكز الصحيه ماكو، بس انا بدي احكي على البريفرال هوسبيتال. مركز صحي it's not responsible to management of severe dehydration. Patient of severe dehydration should be referred to the hospital. لكن اذا البيشنت ما يقدر ياخذ ORS بدنا يحطوا له NG tube start ORS referred him to hospital. زين.
عفوا دكتور، which is faster in the absorption, intraosseous or NG tube؟
لا of course الانتراوسيوس، of course intraosseous، لكن هاي if they are يعني not well trained about the intraosseous access، ما يعرفون، at least put NG tube and give ORS، مو يطلع بفلود through NG tube. then يعني شويه gaining time until the patient reach to the central hospital.
إذا الدكتور هو أبطأ من الاي في مو يعتبر؟
طبعا ابطأ اي في بعد اي في هو الانترا اوسيوس راح يصير بيه بعدين ابزوربشن للسيركوليشن، اما انت بالاي في انت بعد you are directly inside the circulation. صحيح. ماشي،
شكرا.
هسه خلينا نكمل. The child may require multiple fluid boluses. والبارحة جاكم بسؤال انه 2 boluses then there is a correction. مو كافي مرات نعطي واحد، ممكن نعطي واحد واثنين and even 3 boluses of 20 ml per kg for each 20 minutes. وقلنا ايش نختار؟ isotonic fluid. normal saline أو ringer lactate. وحكينا شنو the superiority of normal saline over ringer lactate. زين. هسه الانيشال resuscitation and rehydration phase شو وقت نقول عليه complete؟ خلصنا هسه بعد ما يحتاج نسوي further intravascular resuscitation when the child has adequate intravascular volume. So what are the signs the patient has adequate intravascular volume? انتبهوا the adequate intravascular volume but he is still severely dehydrated. مو معناته there is no dehydration. لكن signs of adequate intravascular volume بدينا نرجع نحس palpate the pulse. هذا البلس اللي كنا ما نقدر نحدده هسه لا قلنا نحسب الريت مالته بس هو تاكيكارديا. زين الفوليوم لو بس دا احسه. بلاد بريشر انا شيكت البلاد بريشر كان هايبوتنشن او حتى ممكن يكون شوك ستيت اندتكتد بلاد بريشر. هسه شبيه لا بلاد بريشر هسه لو there is a blood pressure. بعد level of consciousness بعد شنو ممكن يورن اوتبوت صار معناته الكدني restore its function لان اكو صارفت intravascular volume correction. بعد الكابيلاري فول كانت مثلا more than 4 second ممكن 6 7 second accordingly. هسه صارت مثلا 4 second صارت 3 second. زين هذه signs of adequate intravascular volume. لكن البيشنت شبيه بعده ممكن severe dehydration. لكن من نشوف هاي الساينز نقدر نقول هنا الانيشال resuscitation phase اللي هو الفيرست phase of resuscitation or of management هذا complete. ننتقل للوراء. الوراء شنو هو؟ شوفوا هذا الانتراوسيوس قبل لا اروح للوراء. هذه الساينوسويدز اللي حكينا عليها الميدولاري فينس ساينوسويد موجوده وهذه تروح قبل للسيركوليشن طبعا يعني بون مارو يروح للسيركوليشن فهذه easy to be accessed in cases in failure of intravenous line like this. Then it is very simple. Now, هسه بعد ما خلصنا resuscitation we should put a plan for the fluid therapy وقلنا هاي البلان should be for next 24 hours. من نحطها واحنا حاطين ببالنا 24 اور. شنو هاي البلان؟ شلون احطها؟ هاي البلان راح اخلي بيها احدد type and rate of a fluid. يعني اريد احدد شنو فلويد راح اختار وش قد راح انطي هذا الفلويد. هو 24 ساعه صحيح بس ايش قد الريت مالته؟ هذا يعتمد على 2 factors اللي هي degree of dehydration and the type of dehydration. يعني فرضا هذا البيشنت بعد ما سويت له rapid restoration او initial resuscitation ممكن صار بكوركشن وراح للمودريت dehydration عبر من الهايبوفوليميا والسيفير dehydration راح وين للمودريت dehydration. فرضا there is no further loss بعد ما عنده diarrhea vomiting او بقى severe dehydration. I should assess the degree of dehydration now. وبعد شنو؟ التايب اوف dehydration. التايب اوف dehydration اللي انا كنت suggesting this is hypernatremic or hypernatremic by the clinical assessment. هسه المفروض اني اجت الريزلت اوف سيرم صوديوم بين ما بدينا نسوي الريستوريشن ممكن هسه الليفل اوف سيرم صوديوم اجتي to confirm the assessment of the type of dehydration. زين إذا أسأل سؤال هسه هنا لهاي النقطة which is more important in management or in putting the plan is it the degree of dehydration or the type of dehydration؟ من يجاوب؟
The degree?
Type.
Why it is not the type؟ ليش مو type؟
Because in severe cases, we have a priority to return the tissue perfusion.
Yes.
And all, whatever the type it is.
Very good. The degree of dehydration, it is a prior to know more than the type of dehydration. Why? Because the degree of dehydration, whether it is severe, whether hypernatremic, hyponatremic, the plan of management always it is by the intravenous fluid therapy. While in cases of moderate dehydration, whatever, is it hypernatremic, hyponatremic, راح نروح على البلان of ORS اللي هو oral dehydration therapy. So it's important to know the degree of dehydration more than the level, the type of dehydration. زين. هسه هاي البلان ايش تتضمن؟ اللي قلنا عليها نحددها according to the degree and according to the type. تتضمن replacement and maintenance phase. replacement and maintenance. شنو هو replacement؟ وشنو هو maintenance؟ replacement هو fluid deficit. هذا degree of dehydration سوت لي deficit of fluid. ممكن قلنا moderate, severe or mild. زين. According to this, زين راح احدد percentage of dehydration و I should replace it. Maintenance fluid هو شنو؟ هو fluid that we should receive it daily according to the caloric expenditure. اكو فد فورمولا راح نعرفها هسه، هذه daily in normal circumstances. زين هسه احنا بكيس of loss of fluid, so of course we should meet it. We should replace it. زين. وش عندي بعد replacement of ongoing loss؟ and قلنا if there is ongoing diarrhea and vomiting we should replace it. خلينا نبدي بيه من هسه، نبدي بالdeficit. Fluid deficit replacement it is based on percentage of dehydration. يعني من اقول 10% معناتها severe dehydration، دخلت بالفيلد of severe dehydration، فلازم انطي fluid according to this level of deficit. نحدده by this equation. Fluid deficit, body weight, percentage of dehydration, constant اللي هو 10. يعني البارحة اجاكم بالسؤال الطفل وزنه 9 kg، خلينا ب9. degree of dehydration لأن هو severe dehydration 10%، إذن 9 في 10 في 10 صارت النتيجة 900. So the replacement of fluid deficit صار 900. ليش؟ لأن body weight percentage of dehydration by 10. لو كان moderate يصير نعتبره المودريت هو 6 to 9. ممكن نعتبره ما دام أي رقم تعطي 6 to 9 it is normal or it is accepted. زين. هسه احنا هذا المثال منطيه of 6% dehydration اللي هو شنو؟ moderate dehydration. فطفل وزنه 5 kg he has moderate dehydration his deficit is 300 ml. زين. هذا منو كان؟ الdeficit. Now we will go to the maintenance. How we assess the maintenance? According to a formula called the Holiday-Seeger formula, depending on the body weight and the caloric expenditure per day. يعتبرون if the baby weight is between 3 to 10 kg, so he need 100 kilocalorie per kg. هذا caloric expenditure مالته اللي هو يعادل 100 ml of water. هسه انتم بهذا الجدول ركزوا لي على هذا السايد. If his weight is 11 to 20 راح تبقى الألف، هاي من جت الألف؟ جت من الفيرست 10 kg 100 في 10,000 plus 50 ml per kg for each kg more than 10. يعني اللي وزنه 15 ايش قد يحتاج؟ الوزن 15
1500
1250 Very good. 1250. وقلنا 50 for each kg more than 10. زين. اللي his weight is more than 20. ايش راح نسوي؟ 1500 اللي ذني ثابتات للفيرست 20 kg plus 20 ml per kg for each kilogram more than 20 kg. يعني اللي وزنه 24 ايش قد لازم يحتاج؟
دكتور 1580.
Very good. 1580. هذا الكاريك اكسبندشر. هسه هذا احنا لازم نحفظه، ما نطلعه من البودي ويت. الديفيسيت حددناه، ايش راح نسوي هسه؟ راح نسوي التالي، نجمع المينتنس and deficit fluid given together in 24 hour، لان احنا ايش قلنا؟ البلان فور 24 hour. زين هسه بسيطه، maintenance and fluid deficit are given together in 24 hour. ماشي، شو راح اسوي هسه؟ subtract isotonic fluid already administered in initial resuscitation phase of dehydration. هذا الطفل خد افترض انه اني انطيته 2 بولسز. هاي 2 بولسز مثلا هو وزنه 10 كي جي، انطيته 2 بولسز، each bolus is 200 لان 20 في 10 200 نورمال سلاين، طبعا 200 نورمال سلاين في 2 انا منطي 2 بولسز، ايش صار عندني؟ 400. These 400 should be subtracted. Subtracted يعني نحذفها، نشيلها، ننقصها من المجموع of maintenance and deficit fluid. هاي لازم نشيلها. فالبيشنت مالتنا البارحة اللي كان وزنه 9 كي جي، 9 كي جي وعنده severe dehydration، وش محتاج؟ محتاج 900 للديفيسيت لأن severe dehydration، ومحتاج 900 للمينتنس، صار 1800، وهو ماخذ 2 بولسز اوف نورمال سلاين. ال 2 بولسز ايش قد؟ ال 1 بولس 180 لان وزنه 9 في 20 180 في 2 360. اطرح ال 360 من ال 1800، النتيجه ايش تطلع؟ 1440 سي سي اوف فلويد. هذا يمثل المينتنس and the deficit after subtraction of the isotonic of the boluses should be given in 24 hour. السؤال اجاكم شلون نحسب الريت بير اور اللي انتم بعضكم حله، الاغلبيه حلوا عرفوا راحوا على الرقم الصحيح، ويمكن الاغلبيه سال صاحبه قال له ايش قد الرقم؟ قال له هذا وخلاه هيك. زين مو تمام لو انا مشتبه، وهذا رمضان والله فوقاكم. زين هسه the net amount of fluid.
ممكن سؤال؟
لا خليني اكمل الشرح. The net amount of fluid اللي قلنا بعد ما طرحنا البولس should be given over 24 hours in isonatremic and hyponatremic dehydration. So هنا ايش بينت عندي؟ بينت عندي الامبورتنس انه احدد the type of dehydration، لانه ايش قد راح انطي الفلويد الديوريشن according to type of dehydration. اذا كان isonatremic او hyponatremic there is no difference، اثنيناتهم يصيرن ب 24 hour. اذا كان hypernatremic لا، it should be given more slowly. ايش قد more slowly؟ ممكن يصير 36 up to 48 hour، ممكن اطولها الى 48 hour. ليش؟ to prevent the rapid correction of high serum sodium which may lead to cerebral edema، والcerebral edema تعرفون السكولي مالتها. زين هسه حددنا الاماونت اوف فلويد وحددنا الديوريشن اوف فلويد اذا كان هايبوناتريميك هايبرناتريميك او ايزوناتريميك. هسه بعدنا احنا بالايزوناتريميك والهايبوناتريميك عندنا 24 ساعه. هاي 24 ساعه انطي بيها هذا الفلويد constantly or equally along these 24 hours or according to a specific distribution or specific division. لا، according to specific division. ألزم هاي الأماونت اللي هي مثلا 1440 بالسؤال مالت البارحة. half of it يعني 720 it should be given in the first 8 hours and half of it الباقي remaining اللي هو أيضا 720 it should be given in next 16 hours. صارت هسه كملت ال 24 hour. من أنطي half of the amount in the first 8 hours معناته أنا هنا شو انطيت in rapid rate، انطيت نص الاماونت in rate more rapid than the half amount البقت. ليش؟ لأنه بعد البيشنت in severe dehydration. فأعيد شوية انطي more rapidly. بعدين after 8 hours نفس الاماونت طولت الديوريشن مالتها، سويتها 16 hours. ارجع اقول هذه وين؟ هاي بالايزوناتريميك and in hypernatremic. قلنا بالهايبرناتريميك نطولها لل 48 hours. زين هسه حددنا الاماونت، حددنا الديوريشن، وحتى الديوريشن قسمناها according to the قسمنا 8 hours و 16 hours ما خليناها ثابته. هسه what is the type of fluid؟ شنو هو الفلويد اللي راح انطيه؟ شلون راح اقول هذا الفلويد راح انطيه، ذاك الفلويد راح انطيه؟ هذه according to the body weight. According to body weight. شلون؟ بالتالي if the baby weight is less than 10 kg شو راح انطي؟ انطي dextrose 5% in 0.225 normal saline او اللي سميناه quarter of normal saline او normal saline ابو الربع. ليش؟ السيرم صوديوم مالته بشويه لو اقل من غيره. زين plus 20 ml of the equivalent per liter of KCl. لازم انطي بوتاسيوم، لان اذا ما انطي بوتاسيوم كلورايد وانا اعطيت فلويد راح يصير هايبوكاليميا. بس راح اعرف هسه شو وقت راح انطي البوتاسيوم. if the children weight is more than 10 kg لا، التايب اوف فلويد راح يكون الدكستروز 5% in half normal saline plus 20 ml. يعني شويه انطيت strength of normal saline او الكونسنتريشن اوف نورمال سلاين الاوزمولاريتي مالته اعلى if the weight is more than 10 kg. هذه مهمه نعرفها. زين بالنسبه ليش هاي الاختلافات صارت؟ ليش هاف نورمال سلاين؟ ليش كورتر؟ لانه هذه تعتمد على المينتنس اوف الكترولايت need in the body or requirement. الصوديوم 3 ملي ايكوفالنت، البوتاسيوم 2 ملي ايكوفالنت بال100 كيلو كالوري. هاي يتحقق لي اياها ل 20 ملي ايكوفالنت بير لتر. لكن ما يصير انطي بوتاسيوم الا ما اتاكد انه اكو نورمال رينال فانكشن. شلون اعرف انه البيشنت هاز نورمال رينال فانكشن؟ يا اما انا مسوي بلاد يوريا وكرياتينين طلعت لي نورمال، او انه اني شايف البيشنت voiding. if the patient pass urine معناته اكو normal renal function اقدر انطي بوتاسيوم. اذا لا والله لا هاي ولا ذيك البوتاسيوم should be avoided لانه الريسك اوف هايبركاليميا ان acute kidney injury. زين هذه المينتنس فلويد اللي انا انطيتها هاي اشبيها 5% ديكستروز. هذا ال 5% ديكستروز اللي هو ايزوتونيك فلويد اذا تتذكرون من المحاضره او السيشن السابق، والجلوكوز once inside the circulation it will be consumed يروح زين يظل just water. هذا يعطيني فقط 340 كيلو كالوري بير داي. 340 كيلو كالوري بير داي هاي شو تعادل؟ هاي تعادل 20%، يعني just 20% of the caloric need by maintenance. طبعا هذه low amount، لكن because the baby has dehydration, has diarrhea and vomiting, this is enough to prevent the hypoglycemia and to meet to this level of the caloric requirement. Once the baby is يعني hydration state is corrected هو بعد يقدر ياخذ oral intake وراح يحصل على الفول caloric requirement. زين هسه replacement of ongoing loss. طبعا انا ما اقدر اكمل لكم اليوم المودريت والسيفير ديهايدريشن لانه طولنا بالشرح اكثر من الوقت المحدد، نكمله بسيشن ثاني. لكن خلينا نكمل الريبليسمنت اوف ongoing loss لان this is related to the severe dehydration management. قلنا patient دخل الساعه 9 الصبح، سوينا رابيد كوركشن، حطينا بولس وحطينا بلان، وقلنا هاي البلان نبديها بال10 الصبح اليوم تكمل باكر بال10 الصبح ثاني يوم. زين هذا البيشنت خلال هذا اليوم هو بعد عنده still continuous vomiting and diarrhea. I should replace it. هنا الريبليسمنت اوف ongoing loss ينطى separately. ما ينطى مثل المينتننس اند ديفيسيت، ينحسب نفس التايب اوف فلويد وينطى خلال نفس الفلويد ونفس الديوريشن ونفس السايت. لا، هذا ينطى سيبريتلي، لان هذا يتحدد determined according to what is the type of ongoing loss. شنو هذا ongoing loss؟ continuous diarrhea بعد لو continuous vomiting or both، ممكن يكون both. زين، اذا كان diarrhea loss يعني الطفل مستمر عنده diarrhea، we have two options for replace of the ongoing loss through diarrhea. either نحسب الستول مل بير مل، يعني نجي نحسب الفوليوم اوف ستول هذا اللي طلع مل بير مل every 1 to 6 hours، يعني ابدي من الساعه 10 الصبح مو بديت البلان، اقول من 10 الصبح الى 4 العصر كم مره طلعت بطنه بهاي 6 ساعات. زين، وهذه قد الفوليوم مل بير مل اعوضها او احسبها approximately، انطي 10 مل بير كي جي بير ايتش ستول. فمثلا اجي اسال الام تقول لي طلعت بطنه 5 مرات، يابا 5 مرات طلعت، هو وزنه 10 كيلوات، اذا 5 العفو 10 مل بير كي جي في 10 هاي ايش قد صارت؟ 100 للستول الوحده. زين، 100 مل 5 مرات 500 مل، حددت الاماونت بهالطريقه هاي. شنو هو التايب اوف فلويد؟ التايب اوف فلويد هذا تشوفوه قدامكم 5% dextrose and half normal saline with KCl اللي انا انطيها همينه بالديفيسيت اند مينتننس، لكن شوفوا هنا ايش حاط وياه؟ صوديوم بايكارب. ليش؟
Because stool is rich in sodium bicarb.
There is a lot of loss of bicarbonate through the stool، وهو اساسا عنده severe dehydration ممكن مو تمام، وعنده metabolic acidosis، فenhance the metabolic acidosis there is loss of يعني bicarbonate through the stool، فI should replace it. فهذا التايب اوف فلويد هذا regardless of the body weight، يعني حتى الطفل اللي وزنه less than 10 كي جي وانا اختاريت له فلويد للمينتنس اند ديفيسيت اللي هو ابو الربع نسميه نورمال سلاين، اجيت هنا شو اختاريت له لللوس؟ ابو النص. اذا احسبه سيبريتلي وانطيه سيبريتلي. هذا منو؟ الدياريا لوس. الاميسيس لوس يعني الفوميتنج، قلنا ممكن يصير بوث وممكن يصير one of them. الاميسيس شلون اجي احسبه؟ هم either I have to weigh either replacement of the output يعني الاميسيس mil per mil every 1 to 6 hours او انه 2 mil per kg per emesis. فهل وزن 10 كيلو وات ف20 by each emesis has vomiting 3 times يحتاج اذا 60 ml لازم انطيه، احسب له 60 ml. But what is the type of fluid? Here is just normal saline with half amount of KCl. More the same, half amount of KCl. Not separately. By this way, I prevent the further dehydration if I replace the ongoing loss. زين. هسه وصلنا إلى الفقرة الأخيرة بالمانجمنت of severe dehydration. انطيت initial resuscitation. سويت replacement of the deficit and maintenance. سويت replacement of ongoing loss. حطيت plan for 24 hour. وحددت التايب اوف dehydration والdegree of dehydration وتوصلت الديسيجن this is isonatremic or hypernatremic. اذا البلان اطبقها ب 24 اور. لا hypernatremic اطبقها ب 48 اور. حددت الاماونت اوف فلويد، حددت التايب اوف فلويد، حددت الريت اوف فلويد، كل هذول كملتهم. خلاص هذا هو اكتبهم بورقه واروح احطهم بالطبله وانتهى الموضوع؟ لا، اهم شيء بالموضوع هو المونيتورينج اند ادجستنج ثيرابي. ليش؟ لانه كل هذا اللي سويته it is a matter of approximation، قضيه تقريبيه مو واقعيه. it's not real 100%. شلون not real؟ واحنا ليش قلنا سوينا اسسمنت وعرفنا شلون سوينا اسسمنت. المقصود به انه the baby or the patient is in a dynamic state. هسه هو in severe dehydration، ممكن after 4 hours شو يصير؟ moderate dehydration. اذا صار moderate dehydration لازم اغير البلان مالتي، هاي وحده. هسه هو severe dehydration with correction of hypovolemia، حلو، دا انطي management of severe dehydration. لكن after 4 or 6 hours رجع صار عنده severe ongoing loss ورجع صار in hypovolemia، مع العلم انه انا دا انطي IV fluid وحاسب لي اياه properly. يقدر واحد يعطيني example منه such patient ممكن احسب له الفلويد ويرجع يصير عنده hypovolemia؟ ممكن واحد يقول لي بدي clinical example؟
يعني دكتور بالبرن صحيح هيك يصير؟
بالبرن؟
نعم.
لا 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 لا.
ممكن بالهايبرتونيك ديهايدريشن؟
لا.
ممكن diabetic insipidus؟
ها؟
diabetic insipidus؟
diabetes insipidus؟ لا هم لا.
دكتور DKA؟
DKA شوف DKA اصلا حتى من اجي اسوي مانجمنت زين، هو حتى لو سيفير ديهايدريشن بس من اجي احسب له الديفيسيت اجي احسب له الديفيسيت مال مودريت ديهايدريشن، لان هو عنده هايبر اوزمولر ستيت اللي سوت عنده ديهايدريشن. سولفنا ذاك اليوم الميكانيزم اوف ديهايدريشن، حتى من اجي احسب له الديفيسيت تحسبيات ماليه فما يرجع يصير عنده هايبوفوليميا. بيشنت اوف DKA ما يصير عنده هايبوفوليميا.
بلي دكتور.
اي من يعرف؟ احمد عبد الرزاق ممثل الجروب، سكتنا عنك هوايه، وينك؟
نعم دكتور موجود.
موجود، زين يلا جاوب هسه. قد انا حاجة احكي لك اياها بالعربي. الطفل دخل عنده، راح احكيها هسه اوضح لك اياها. دخل عنده دايريا وفوميتنج وحسبت له كان هايبوفوليميا وحسبت له وانطيته بولس شوت زين، واخذها وصار عنده هسه يعني جود انترافاسكولار فوليوم وحطيت البلان مالتك، واجيت ورا 6 ساعات او ورا 4 ساعات لقيت راجع مره ثانيه صار عنده هايبوفوليميا ورجعت حطيته من جديد نيو بولس وهكذا. منو هذا؟ وين هذا؟ يا بيشنت يمكن، وانا اقول دايريا وفوميتنج، انتبهوا انتم البقيه، لا دايابيتس انسيبيدس ولا DKA ولا بيرن ولا غيره. هم diarrhea or vomiting. But which cause of diarrhea or vomiting؟ ها؟ شو تقول يا احمد؟
gastroenteritis مثلا.
Very good كاليرا. Very good احمد، عافية عليك. شلون عرفتها؟ وحدك عرفتها لو واحد غششك؟ عيد الجواب احمد، عيد الجواب. ايش قلت؟
دكتور قلت gastroenteritis بس الظاهر سمعتها كوليرا.
ولك مو انا غششتك بالجواب، ايش فيك انت؟ كوليرا. Vibrio cholera. Because Vibrio cholera causing severe secretory or osmotic diarrhea، شو تسوي؟ secretory diarrhea. severe intractable secretory diarrhea. تنطي فلويد والبيشنت يصير عنده لاص، تنطي فلويد والبيشنت يصير عنده لاص. فممكن انه حتى تحط البلان ويرجع مره ثانيه البيشنت يصير عنده because of severe ongoing loss يصير عنده hypovolemia من جديد. لذلك المونيتورينج is very important. زين، لا هاي ولا ذيك، لا صار عنده moderate dehydration كان سيفير صار moderate، ولا سيفير صار hypovolemia. بس ممكن الفلويد اللي انت ايش خلي اعطيته ممكن ايش سوى؟ ممكن ما مشى بالشكل الصحيح for one reason or another، ما استلم فبقى البيشنت in his condition، او انه ممكن مشى rapidly، ممكن سوى عنده volume overload، ممكن سوى عنده signs of congestive heart failure. يجي هنا your role in monitoring in follow up then in adjusting the therapy. هاي البلان اللي حطيته ب 24 hour هذه مو قانون، تلزم الورقه تشخطها ترجع تغير البلان مالتك. زين ممكن تدز انفستيجيشن تشوف صار عنده فد الكترولايت ديستربنس، ممكن صار عنده هايبوناتريميا، ممكن هو كان نورمال صار عنده هايبوناتريميا وصعد الصوديوم فيري هاي. هذا يجي الرول اوف مونيتورنج. فايش راح تسوي؟ قلنا هذا كل اللي حكينا is only approximation. زين فاتس ايكوال انتبهوا العباره important to monitor the patient during the treatment and to modify therapy on the basis of a clinical situation. تيجي تشوفه بعدين شنو اللي صار عنده، واصلا هو ongoing loss طريقه حسابه هو type of monitoring and adjusting therapy. هسه عنده 4 times انحسبت له فلويد هالقد انطيته، بعد 6 ساعات ما عنده نهائيا فما يحتاج هذا الفلويد. شنو هو المونيتورنج مالتك؟ شو راح تسوي؟ toward what؟ الفيتال ساين، البلد بريشر and pulse rate. This is very important. قلنا يعطينا الهيمودايناميك ستاتس، الانتيك اند اوتبوت، يعني لازم يصير بالانس between the fluid intake اللي انت تنطيه وبين اليورين اوتبوت. اذا انت اعطيت فلويد وماكو يورين اوتبوت يشبه اللي انت اعطيته، يعني قصدي بالانس with. هاي ممكن المشكله صار عندك انت طبيت فد اوليجيوريك acute kidney injury، مرات بالعكس يصير يعني polyuric phase accordingly. هاي لازم تحط بالك من عندها. بعد physical examination weight، ممكن اعطيت فلويد والطفل صار زين اوفر ويت بسبب شنو؟ الفوليوم صار اوفرلود، او بالعكس ساينز اوف ديبليشن صارت عنده. والمونيتورنج اكيد علما للالكترولايتس، شوف الليفل اوف صوديوم اللي هو اهم شيء، البوتاسيوم، تشوف الشوغر، تشوف الكالسيوم، كلها هاي تشوفها. لهنا ننهي السيشن لانه بعد عندنا ان راح اشوف اذا باكر او عقبه، ما اعرف اقول لكم ان شاء الله اذا باكر اثناء النهار او عقبه. يعني نشوف الاو ار اس، يعني نشوف المانجمنت اوف ذا مودريت ديهايدريشن اند سيفير ديهايدريشن، زين سوري المايلد ديهايدريشن، ونحكي عن الدبليو اتش او، لان دبليو اتش او كلش مهم. باكر انت تتخرج تتعين او تداوم فتره من الانترنشيب مالتك في مستشفى السجاد، في مستشفى المشخاب، في مستشفى القادسيه، وما عندك البوسيبل يعني الفاسيليتيز سوري انه تسوي اكاديميك، فتتعالج according to the WHO وتسوي stabilization of the condition of your patient وبعدين يرفعهم. فلازم تعرف هم ال WHO شلون يشتغلون. اذا نرجع بس على مود ننهي السيشن. البارحه اغلبكم اخطا بالسؤال الاول، والغريب بالموضوع خل انهي الشو زين